I'm John Emery, Professor of Primary Care Cancer Research at the University of Melbourne. I'm part of the research team responsible for Data for Decisions, the Department of General Practice research initiative. We're creating a repository of data from de-identified electronic medical records, known as Patron. This is a very exciting project that we want GPs and the public to know about. Data for Decisions opens enormous possibilities for the generation of knowledge to improve healthcare practices, services and health outcomes. Our data privacy, security and governance measures are second to none. Keep watching to learn more about Data for Decisions and look at our website.
Beside me is Dr. Jane Crowe. She's a GP who wants to know more about the program to help her decide whether or not to involve her practice. To discuss the program, we have here at the table two of the lead researchers, Associate Professor Dougie Boyle and Dr. Joanne Manski-Nankervis, who happens to also be a GP. We also have Tricia Greenway providing a community voice, and Dr. Malcolm Clark, a GP who is supportive of this project. Dougie, I sort of want to start with you here because you've sort of led a lot of this. It's called research, the research program is called Data for Decisions. Yep. Can you tell us what data we're talking about and what sort of decisions we're actually looking into?
What is a bit of a gap in Australia right now is having good primary care data, and we're talking about in particular routinely collected data that is collected during consultations. And the challenge we have is that if you want to improve healthcare, you really need to be able to look at the patient journey of care.
A really key part of this is that we do have data and we do have decisions. Mm-hmm. So this is certainly not a case of just taking lots and lots of data from general practice and us publishing studies about epidemiology. In fact, what we want to do is take that data and then think, okay, how can we feed this back to develop interventions or tools that then can help GPs and patients make decisions together about how we can optimise their health.
And in terms of the research program itself, I mean, what would a GP have to actually do?
In terms of any work for the GP, the system just sits there in the background, and once a week information contributes into the Data for Decisions repository. So initially, there's probably a couple of hours work there whilst we help set up some technology for them. Later on in the programme, there are some exciting things that we're aiming to do, which might be intervention projects, maybe that Joanne can talk to more, but certainly we want to, if we involve GPs in any of that, it's through further asking them if they want to be involved in projects like that.
There's a lot of different kinds of work that we can do with this. As Dougie mentioned, we can look at the journey that somebody has from the community through primary care through to the hospital and think about, okay, so what does the data tell us about maybe being able to pick somebody up earlier in that journey and maybe to be able to intervene and stop them from ending up in the hospital. Might be something as simple as a quality improvement project in a general practice to help them identify people that might be at high risk of developing a heart attack in the next 5 years, so that they can do something about it and they can look at the data that we provide back to them to see if that has been effective. The other thing it could do is when we are carrying out randomised controlled trials in general practice, we might be able to help the GPs to find people in their practice that might most benefit from participating in those trials.
Tricia, you're the sort of consumer voice at the table. you're the one that has to be convinced in a way, amongst others. But how does the consumer voice sort of see this sort of project? I mean, where's the interest from your perspective?
When you ask people about being involved in any sort of research gathering, they always say, well, if it helps. And they like to be reassured that they're part of something that's going to, even if it doesn't benefit them immediately, that it will input into some good for the community. And I tested this out this morning with a group that I talked to, and they were just saying, oh, that just sounds like plain good common sense. They didn't raise a lot of objections, but they did just ask, so are people going to be reassured that this data is going to be, safely managed? And we talked a little bit about the de-identification aspect of it, and they all just said, oh, that sounds really good. It'll probably take a while, They even saw that immediately.
Yeah.
Take a while, but it really will be a contributor to what often people talk about is the lack of evidence.
Malcolm, you're a GP
I
who's
am.
engaged in this project, so you're converted. How did you get to that point? I mean, you have a business to run. This is a big deal, and there's a patient trust here that you have to make sure you link in with well.
Sure.
Why is this research important in your sort of context as a GP?
Well, I suppose my conversion has been in relation to how fabulous the wealth of knowledge we can get out of our GP data. So following on to what Joanne was saying, we usually use hospital groups to do research on, and they're not really representative of the community. So when we give information back to the community, we're talking about a very specific small group. And, we have a fantastic amount of information in our general practice. Some of it is not as clean as we'd like, but, again, looking at something like this will help the GPs and the people want their data to be of better quality so that it can be used for what Trish was saying, the expectation that if GPs collect data on your behalf, that we use it for reasons that are going to help the community. The thing that gets me in with this sort of stuff is we can't just sit down and ignore the quality of this data and just leave it on our servers at our office. We need to actually bring it out and find a use for it.
Joanne, sharing of data is a controversial issue, whether it's financial data or other data. When we get to health, people get really edgy about that.
Yeah.
How do we go about, making both consumers but also GPs that have custodial control of this data feel comfortable with this project?
I think that's a really important question, Shane, and it's something that we've literally spent years working to this point.
We have.
Because we have a very strong commitment to doing whatever we can to protect people's privacy, to make them feel confident, to show them what kind of ways that how we're using their data and how that might improve their care. So what I can say is that we've spent a lot of time, and we're going to continue to evolve this to make sure that we keep up with best practice, a strong governance framework. We've got technology that can de-identify data before it even leaves the practice of both patients but also the GPs and health professionals, which we think is something that's a bit unique. We have ethical procedures, so every time somebody wants to access the data for research, they have to have ethics approval. Our program of work has undergone an ethics process here at the University of Melbourne. And we also do have legal expertise in our data governance committee to make sure that legally we are doing everything that we can to protect that data and deal with it appropriately.
Dougie, the software that you've developed, that this whole program is based on, the Granite tool, takes this into account. It's been used for quite some period already successfully, is that right?
Granite, the research and implementation started 12 years ago now. So from the start with this software, the brief and the thoughts were around how can we actually develop something that can give reassurances that when we actually use data, it can be used in the right way. We've worked with the different research groups to discuss, just what is it that's required around the security provisions.
The data security is one part, but Joan, the other part, of course, is consent from patients. How do you ensure that you actually have consent?
There's two levels of consent, Shane. The first consent obviously is from the practices that are participating, so it's the health professional level, and then as you mentioned, what do we do at the patient level? So what we have for this program of work is applied a concept called a waiver of consent, and that's consistent with current national NHMRC ethics guidelines. And a waiver of consent means that we don't need to seek specific informed consent from the patients that whose data we're extracting. And I'll just take a second to explain why, because I think it's a very important point. In a general practice, you might have up to 10,000 people that are attending your practice. So what our ethics statement says, one, is it practical to get informed consent from all of those people? I think that we would agree that it's probably not. The second thing is, are we going to be taking all of the precautions we can to de-identify those people to the extent that we can and to protect their data? So are we collecting names and things like that, or no, we are not? And so for that reason, we aren't seeking specific patient consent for their records to be transferred in. Patients will be able to have the right to withdraw. We're going to be advertising in the clinics that are participating with posters and pamphlets and things like that. We're not doing this in secret. We do want the practices to be make it fully aware to their patients that they are participating in this, and we are respecting people's right to withdraw if they do not. But we are really doing this for the public good. We feel that even though there are some people that would prefer not to share their data, there are a lot of people that, as Tricia mentioned, would like their data to be used as long as it's done in a safe way that respects their privacy, to help generate important data that can be used to hopefully improve the health of the community.
Tricia, I might just get your response on that, because this idea of 10,000 odd patients and not all of them being completely aware but being able to opt out, I mean, as the consumer representative, does that feel like a reasonable approach?
Every group I talk to really does like to think that they're contributing to further knowledge, and that maybe somebody doesn't have to put up with something that they have to. You know, it's a real point of observation with people. But I do think that it does need so that there's not a big use of time in explaining this to a person's, personal appointment. That there does need to be information out in the office, and there does need to be a broader communication strategy, a bit of excitement about it all. Right?
Jane, you're one of the ones that we have to convince you. You've heard of
What do you think of that, Jane? Please, let me answer any further questions you have on that.
What sort of information would you actually need to feel comfortable signing up to something like this and recommending it to your many GP friends?
Trying to understand it from the nitty-gritty and the general practice day-to-day basis. Firstly, just the security of the patient data that Dougie was talking about, and because once this information has left our practice, it's escaped and we don't know where it's going, and so we're trusting you to be looking after it and in ethical ways.
I'm here then to work with the university security teams. We've got a cyber security team. We've got their main IT teams, and we work with them as we have done for quite a number of years now. So we've got quite a lot of experience in doing this. And we work with them to proactively check things like the security is as good as we can make it. And if people are coming in to do research projects, we want to know what data do they need. So we'll go through ethics review, but also through this governance committee, where questions like this are asked. What can we provide and how is it provided? Then external parties would have to sign an agreement that goes over and above the law in terms of the steps we ask them to take and the things they can't do with that data.
Will practices have access to their own data for quality assurance and improvement purposes, or will they be notified what research is coming out of this
Yes.
Yeah.
So the aim here is for complete transparency. So our website will have information of every project, and we also have we'll be having an obligation on the research groups who are undertaking research for regular updates that will be on there. So it's not just someone asks for data and we never find out what happens to that. So that's going to be in there. In terms of the quality assurance, some of our research projects are quality assurance projects. So we want this to be something that works for practices, that's for sure.
Well, Dougie, before we finish up, I might just ask you, with regards to the practices agreeing to this, what sort of happens next if a practice wants to get involved?
Okay, well, basically it's quite straightforward. We've got a website, Data for Decisions. So we'd be delighted for people to get in touch with us, and we look forward to making a difference.